Scan the QR code.
Hello, everyone, and welcome to our Plasma Exchange webinar. As you know, that we have finished a couple months ago very successful virtual workshop on CRRT, and today we are focusing on another virtual training, which is a Plasma Exchange, starting with essentials, basics, strategies, and going to in-depth case-based discussion. We have very good speakers and a panel of expertise today. So we are gathering very experts from both critical care and nephrology. We have Dr. Kamel El-Attar, who is going to be our main speaker today from Baxter in the Middle East. Professor Hesham Elsayed, who is a professor of nephrology in Shams University, Cairo, and he is the president-elect of the Egyptian Society of Nephrology. Dr. Marcus Browman is a senior critical care consultant from Sweden. He works now in United Arab Emirates. Dr. Jacobo Bacariza is originally from Spain, and he is a senior critical care consultant in Portugal now. And here is our agenda today. So we have our first part of the workshop focusing on basics and essentials and strategies of plasma exchange by Dr. Kamel El-Attar. Then Professor Hesham Elsayed is going to moderate the session. So we'll have about 5-minute QA session. Then we will have the second part of the workshop with case-based discussion. Then Dr. Marcus Browman and Dr. Jacob are going to moderate the session with another 5-minute of discussion and the QA session. And without further ado, we are going to start our first part of the workshop, focusing on basics, essentials, strategies of plasma exchange.
Welcome back. My name is Dr. Kamel El-Attar, and today we will be talking about TPE, therapeutic plasma exchange, some known as total plasma exchange. Very important therapy. It is of growing indications. We see more and more patients needing TPE in the ICU and also outside the ICU. So today we will be discussing the technique, how to do it. We will also look at the prescription. How can I prescribe TPE once I decide to start? We will talk a little bit about anticoagulation, a little bit about considerations, as well as some precautions. So by the end of the session, you should be able to prescribe TPE using the CRRT machine, or the machine that is originally used for CRRT. After that, we will go into a case where we will have a patient case simulation. You will, in this case, try to prescribe TPE for that patient, and then we will go on the machine to try to upload that prescription on the machine and again see how it looks like. So we will try to see what's a good TPE prescription, what would be a low clotting risk TPE prescription. In general, there are two techniques for TPE. One of them is known as CTPE, which is centrifuge TPE, and the other one is MTPE, which is membrane TPE. The one that we will be discussing today is the membrane TPE. So the same idea is the same. The idea is that we will try to separate the plasma from the blood, get rid of all that plasma, and replace it with a replacement fluid, whether fresh frozen plasma or albumin. Why do we do that? The idea is we're trying to get rid of something in the plasma, a substance in the plasma. So one idea is, why not get rid of the entire plasma of the patient and replace it with either fresh frozen plasma or albumin. Both techniques do the same. There is no superiority of one technique over the other. They have the same results. It is mainly availability, training, cost, and so on that may you make the decision between CTPE and MTPE. But today we will explain how to prescribe membrane TPE. Of course, the benefit of doing membrane TPE is that you're going to be doing it on already the machine that you have in the ICU, the CRRT machine. So this is not an extra machine. This is one of the main advantages of having membrane TPE. The second advantage of having membrane TPE is the circuit is much smaller. So you will see the extracorporeal circuit could be down to 72 ml. In this case, you will be able to do low body weight patients, pediatrics, where a lot of those diseases that we will see are prevalent in that age group. Also, you can use heparin anticoagulation or no anticoagulation with the CRRT machine, but with the centrifuge, you have to use citrate anticoagulation. Some patients, of course, are obviously contraindicated for citrate, severe liver damage, or patients with severe hyper or hypocalcemia. Those patients are not going to do well on citrate anticoagulation. The main advantage of the centrifuge TPE is, of course, that it does not need a central line. So the patient is actually mobile and doing well. You can do centrifuge to a peripheral line. So in this case, you don't need to insert a central line, the complications and the risks of the central line. So this is a quick review between the two techniques. Of course, today we will focus on the membrane TPE. You will see that, the blood comes in here from the patient, very obviously from the circuit, into the filter. In this case, the plasma filter is very different from the CRRT filter. How is it different? The pore size. The pore size is huge. The cutoff is around 2 million Dalton. In CRRT, the cutoff of the membrane is somewhere between 20 and 40,000 K Dalton. 20 and 40,000 Dalton versus 2 million Dalton, which is huge difference. And what does 2 million Dalton means? Means everything goes. So all the plasma, the toxins, the drugs, everything except, of course, the cells, the RBCs, the white BCs, and the platelets. Those ones will not go, but everything else goes. Goes where? To the effluent. As you can see from the circuit, the plasma will go to the effluent. And in this case, the post replacement, which is in this case, the post pump, will act as a replacement pump. It will replace the plasma that we are removing in the effluent at exactly the same rate that it is being removed. So we will have two pumps running. One of them is the post, the replacement, which is replacing whether fresh frozen plasma or albumin, exactly at the same rate that we are the effluent pump, which is getting rid of the plasma. In this case, there is no fluid imbalance. Hypotension or drops in blood pressure will be much, much less likely because the system is automatically linked together through the machine. So in this case, this is how the circuit looks like. You will see you get rid of the plasma in the effluent, you replace it with fresh frozen plasma. We will go into the prescription, but this is the whole idea, the concept of using the CRRT machine in membrane TPE. Of course, the question is, why would I do that? Why would I use TPE? We have CRRT. We can remove molecules. I talked about dangerous molecules. We can remove many different toxins. With CRRT, we talked about adsorption. We have to understand that when we are using TPE, we are targeting very, very large molecules. So these molecules are huge, that therefore cannot be cleared by convection or diffusion in CRRT. Of course, if they were small, we would have done CRRT. But also they have to be intravascular, something that we can see in the blood, so we can remove. If the toxin is in the tissues, we can't help. Also, it has to be something dangerous, like a toxin or endotoxin, or in the example, autoantibodies and so on. TPE, again, is designed for humongous, large molecules, not middle molecules, but we're talking about huge molecules, and I'll give you some examples later. Most commonly, autoantibodies, autoimmune diseases, we are all familiar with that. TPE for removal of autoantibodies, patients improves a lot. After you remove those antibodies, immune complexes, cryoglobulins and cryoglobulinemia, myeloma light chains and multiple myeloma, endotoxins in septic shock. So many indications, all of them where you want to remove a huge molecule and you want to clear the plasma of that molecule so the patient would improve the outcomes. Of course, also very high cholesterol, above 1,000 milligram. In this case, those patients also would benefit from TPE. Cholesterol being a huge molecule, you will see will be removed quite effectively in a TPE session. Okay, so which diseases, what indications? We have to understand there are hundreds of indications for TPE, and the best way to go by that is to go through the ASFA guidelines. The American Society for Plasma Apheresis guidelines, they are published and renewed every almost 3 years. The most recent, I think, was 2023. We will take a quick look at the ASFA guidelines 2023 to see what kind of indications there are. Am I indicated for TPE or not? Is this disease indicated for TPE or not? The most common, of course, the Guillain-Barré, the myasthenia, the lupus, TTP. These are the most common neurology, hematology diseases that get referred to TPE programs. Nevertheless, there are many, many others. And when you go back to work tomorrow, a colleague comes and says, I have a patient with, for example, optic neuritis. I have a patient with mushroom poisoning. Is he or is she indicated for TPE? The answer is, we will go through the ASFA guidelines. As we're going through the ASFA guidelines, I will show you how to be able to check out the disease and see what is the indication for TPE. So if you look through any search engine for ASFA guidelines 2023, you will have access to the guidelines. You can download them, and you can see that the guidelines here are published every 3 years. So the most recent would be the 2023. And you have, for example, a colleague coming to you saying, I want to know what is the role of TPE, for example, in multiple myeloma. I don't know. There are over 100 indications for TPE. So what do? We open the guidelines, we control find myeloma, and you can see multiple myeloma cast nephropathy. Page 183 is a category 2. So category 2, as we said, is a second line treatment. We go to the page 183. We will find the multiple myeloma, as you can see here, as myeloma cast nephropathy. Category 2, as we explained, the evidence grades 2B. So what do I need from this guideline? I need to know the current rationale of TPE, the treatment. All of this is written explaining, why TPE, which patient, when to start, and so on. But also the more important is the technical part, which we will need today. In this case, how many PECs can I use for the patient with multiple myeloma? I can use 1 to 1.5 PECs. How did I get that? I got it here from the ASFA guidelines, volume treated 1 to 1.5 total plasma volumes. What is the replacement fluid? Here it is mandated to be albumin. Now, do I have the choice between albumin and plasma? No, here is clearly albumin. And as you can see, the frequency is daily or every other day. And I keep doing it until I get a 50% reduction in free light chains. That means you're doing a good clearance, and that means that will dictate how many is it daily or every other day until you achieve, on average, 10 to 12 procedures over 2 to 3 weeks. This is the technical notes, and that's how I know the prescription for multiple myeloma, for example. So this is how to navigate the ASFA guidelines. When we go to the cases, we will have to go back to the guidelines and check the technical notes for each indication. So from the TPE ASFA guidelines, you saw a category 1, 2, 3, and 4. Category 1 means first line treatment. You should start TPE immediately. Category 2 means that once you have medical treatment has failed, it's a second line treatment. You should start TPE. Category 3 means you can start TPE if you decide, you and your colleagues, that this is the best way forward. You can try TPE. Category 4 means don't try it. We've tried it before and it doesn't work. So these are the 4 categories from the ASFA guidelines. And when you go through them, you will be able to find out which disease belongs to which category, be able to make your decision whether to start TPE or not, built on the ASFA guidelines for 2023. Of course, once you have decided to start TPE, the second step is to prescribe. How do I prescribe TPE? Now, the first step in prescribing TPE is trying to identify the total blood volume of the patient. Because if I know how much blood you have, I maybe also try to estimate how much plasma you have. So when I know how much blood you have and I know how much plasma you have, now I can start exchanging that plasma for you. So we start by the patient's weight. We estimate total blood volume by multiplying the weight of the patient by 70. For example, patient is 70 kilos, multiply 70 by 70, you get 4.9 liters, almost 5 liters of blood in an average 70 kilo patient. We all know that. This is the first step to prescribing TPE, identifying total blood volume. Now, second step is trying to understand how much is the plasma volume. How much is your patient's plasma volume is easy. You get the blood volume, you multiply it by 1 minus hematocrit, because blood is two components, hematocrit and plasma. So if I get, if I know how much is the hematocrit, for example, hematocrit is 40%, therefore the plasma is 60%. So I multiply that 3 liters by 0.6, I get the total plasma volume. This is how much plasma you have in your blood. Once I know that, the next step is to see how many times over do I want to exchange your plasma. So for the numerical example we talked about, the patient has around 3 liters of plasma in his blood. In this case, I know that the 70 kilo guy with hematocrit of 40% has 3 liters of plasma in his blood, for example. Now, how many times over do I want to exchange those 3 liters? This is the question now. In TPE, we have something called the exchanges, the PECs. How many PECs do I want to do per session? With every treatment, every session, I want to know if I will do 1 exchange, 1.5 exchange, 2 exchange, and so on. So how many times over do I want to change your blood? How do I know that? Depends on each disease. How will I know each disease PECs? By going back to the ASFA guidelines. Again, as I showed you earlier, you can go through the ASFA guidelines. It will tell you the category, and it will tell you also the PECs, how many exchanges do you expect to have. It will also tell you, the frequency, how many sessions, and so on. So the last thing is, for example, you're going to do 1.5 PECs, you have 3 liters, then you want to do 4.5 liters of plasma exchange. This is where the prescription starts. So we will be repeating that in a couple of examples until everyone was familiar to see how they can calculate the total exchange volume. Total exchange volume is the PECs multiplied by the total plasma volume, which means how many times over do I want to exchange the patient's plasma. So in this case, patient, for example, as we explained, the weight multiplied by 70, if he's 100 kilos, we talk about 7 liters of total blood volume. So his total blood volume is estimated around 7 liters. Of course, you have his hematocrit here. In this case, is 42%. So 1 minus hematocrit is 0.58. That would be his hematocrit. 1 minus hematocrit is 0.58. You multiply it by 7 liters, you get 4060. This is 4 liters of his total plasma volume. So in this example, the patient with weight 100 kilos, hematocrit 42%, he has around 4 liters of total plasma volume in his blood. Now, what's the next step? We try to identify how many PECs, how many exchanges. Usually, we do a minimum of 1 exchange. So in general, as I explained, there are hundreds of diseases. Each of them have their own indications. But in general, we do usually not less than 1 exchange, but we always do not more than 2 exchanges. Somewhere between 1 and 2 PECs is most of the diseases. How do I know which one is this disease? Again, you go back to the ASFA guidelines where it is very clear which of the diseases has how many PECs. You identify that number of exchanges, the PEXs, you multiply it by the 4 liters. You found in the ASFA guidelines for this particular disease, it was 1.5, so 1.5 exchanges. You multiply 1.5 by 4 liters, you get 6 liters, which is, in this case, the total plasma volume. So this becomes your total plasma volumes. I need to prepare now 6 liters of replacement fluid. I will either call the blood bank, try to prepare for fresh frozen plasma, or I will call the pharmacy and start preparing albumin. So I want 6 liters of albumin, or I want 6 liters of fresh frozen plasma. We will come to that later, but this is how we prescribe TPE. Another example here, you see, patients weight 100 kilos, hematocrit is only 34%. You want to do 1.5 PEX. How can you do that? Another numerical example now, patient still 100 kilos, but hematocrit is 34%. So what's the first step now? Total blood volume is 100 times 70 is 7 liters, yes? Second step, 7 liters multiplied by 1 minus hematocrit. What's hematocrit? 34. 1 minus 34. 0.66. 0.66 multiplied by 7 brings me to 4620 ml is your plasma volume. Now, what would be your total exchange volume? The question is how many PEX, how many times over do you want to clear that plasma? The answer is 1.5. So you multiply this 4620 by 1.5, you get around 7 liters of replacement. This is how, again, you calculate total plasma volume. This is how you prescribe TPE. So the whole idea is I'm going to take 7 liters of this patient's plasma, I'm going to throw it away in the effluent, and I'm going to be replacing it with the 7 liters of replacement fluid. One thing is getting rid of the toxin or the autoantibody or the immune complex or whatever that was in the blood, the toxin that was in the blood. And the other point is also replacing it with 7 liters of fresh frozen plasma, or in this case, albumin. How do I make the choice between albumin, fresh frozen plasma? How do I make that choice in replacement fluid? The answer is you don't. Again, the ASFA guidelines, they tell you which disease needs to be replaced by which fluid. So when you go through the ASFA guidelines, you will find, for example, disease A has to be albumin, disease B has to be plasma, and sometimes the ASFA guidelines will tell you whatever. If it is whatever, you can choose. Of course, we all know the advantages of fresh frozen plasma replacement. Why? Because we have already have clotting factors there. We already have antibodies there. So in this case, fresh frozen plasma definitely has clotting factors, has immunoglobulins, has complement. So the patient's not immune compromised and will not have a bleeding risk. If I replace with 100% albumin, there is no clotting, there is no clotting factors, there is a high bleeding risk, there is an infection risk. Of course, if I use plasma, 5 liters, 4 liters, 6 liters, each bag of plasma in each country is different. So it's ranging from 200 to maybe 300 cc per bag. If we talk an average of 250 cc per bag, if I'm using 4 liters, that means I need 16 bags. So 16 bags from 16 different donors. So the risk of hepatitis is high. The risk of mismatching, finding 16 bags, also the risk of, as I explained, allergies. Are we going to develop allergy because we are getting all these donors? So the risk of having fresh frozen plasma in this case is high. Cost issues, availability. Who has this number of cross-matched plasma available all the time? Because this is just one session. What if it is daily for the next 7 days? Will they have 16 bags of plasma ready for me to do only 4 liters? So these kind of availability, cost, and so on, they play a big role in deciding whether to choose albumin or to choose plasma, if you're given the option to choose by the ASFA guidelines. Last part, you have prescribed TPE. Now you want to anticoagulate the patient. Of course, we will either use heparin anticoagulation, or we will use no anticoagulation. Heparin anticoagulation, of course, we all know the protocol. We talk about 10 to 15 international units per kg per hour. Some people start with a bolus of 5,000 units and then 10 to 15 international units per kg per hour. The idea is to try to keep the patient within an APTT 1.5 or 2 baseline. It is systemic heparin anticoagulation, so the patient is fully anticoagulated. The other option for some patients where heparin is contraindicated is to try to do zero hep or no anticoagulation. Again, we go back to the filtration fraction. As we explained, the higher the filtration fraction, the higher is the pressure on the filter, the more likely is the filter to clot. So we try to maintain filtration fraction below 25% in fully heparinized patients, below 20% in non-anticoagulated patients. So this is what we do with anticoagulation. We will come to the case and you will see how filtration fraction would change whenever we change the rates, the blood pump speeds, and so on. So there are different parameters in the prescription that will alter the filtration fraction, the more likelihood of this filter to clot. Of course, you know, TPE can have some adverse events, as we explained, those of them related to the therapy itself, or to the catheter, just inserting a central line, or to the fluid. So there are different complications or adverse events that can happen during a TPE session. Of course, also remember, when you're doing TPE, everything goes. So plasma goes, but also antibiotics, drugs, and everything. So you need to schedule your drugs to be before, after the TPE session, so you don't lose everything during the TPE. So if you're having the antibiotic dose, you immediately after the treatment, next day, then immediately after treatment, because during the session, you're going to be getting rid of a lot of everything, including the drugs and so on. So this is important to remember also. Patients who are on ACE, better stop 48 hours before the treatment because of allergies. Precautions for TPE. So whenever we're doing TPE, remember we are going to get rid of plasma, which contains calcium, and we're going to be replacing, for example, with albumin that does not contain calcium. Or we're going to be replacing with fresh frozen plasma that also doesn't contain calcium because it is chelated by citrate. So in both cases, we are going to be having a risk of hypocalcemia. It is wise to have a precaution of intravenous calcium infusion throughout the session, and some people have a bolus in the beginning, then infusion. So the idea is to try to prevent hypocalcemia by giving calcium chloride or calcium gluconate infusions. Also, there is a risk of hemorrhage if we're going to be replacing with albumin. There is no clotting factors. The patient has higher risk of bleeding. One good advice is to always give a couple of units of plasma at the end of the treatment, even if you are going to be replacing with 100% albumin. Also, it's good for the infection because, when you do that, you're giving also some antibodies, some complement. So again, some people would use IVIG to be able to prevent or mitigate the risk of infection when replacing with albumin. Of course, hypokalemia, again, the same point. We're going to be removing a potassium-containing solution, which is plasma, and going to replace it with a solution that does not contain potassium. So that's why it's important to use ringer lactate or ringer acetate or plasma light potassium-containing solutions when preparing the replacement solution with albumin. So there's albumin and not normal saline, but albumin and some physiological solution like plasma light or ringer acetate or ringer lactate. Of course, there is also other risks, the risk of hypothermia. We're going to be using fresh frozen plasma. We saw big volumes of frozen plasma. So thawing the plasma is very important. Warming the fluids, also warming the blood, using the blood warmer on the CRRT machine to prevent hypothermia. ACE inhibitors should be stopped, as we said, 48 hours before the treatment because of allergic reactions. Of course, in general, don't be surprised when you get an allergic reaction. You're doing a TPE with, for example, 4 liters of plasma coming from 16 different donors. The risk of hypersensitivity reactions is very high. We always use a precaution by giving some sort of steroids, before you start the treatment to prevent the allergic reaction. So these are all good tips and hints to have when you're going to prescribe TPE. I wish you enjoyed that session about TPE prescription. We talked about indications, how to prescribe, some precautions to do, and a little bit complications of the treatment. I hope you enjoyed that and ready for a case presentation.
Thank you very much, Dr. Kamel El-Attar. It's a very comprehensive, and you get the tips of the technique and how we do it, from starting the vascular access, the differences between centrifugation and the membrane filtration. And you perfectly described that we shouldn't go above 1.5 the plasma because it's caused with no effect. There is many questions. I will start with just my opinion that according to the volume of distribution of the most of immunosuppression, which is the common challenges to give steroids, cyclophosphamide, etc. Most of these drugs have very long distribution, so it usually does not affect the doses. However, rituximab should be absolutely given after the session because it's completely removed as a monoclonal antibody and present only in the vascular compartment. There is a lot of questions. I will try to just summarize and will help for your answer in a short way. First questions was from seeking the ASFA guidelines. We will send it shortly. Second question is about how we should provide plasma exchange, nephrologist or hematologist. I think for the technique, it's only for nephrologists, but the indication may be sharing from neurology, hematology, and other specialty. Another important question is coming, which weight we should use to calculate the total body volume in extreme obese patients? What do you think?
That's a very good That's a very good question. I think am I echoing?
No, it's okay. I'm hearing you well.
Okay.
So the dry weight or the ideal weight or the patient weight, we know that CRRT you calculate it from the present weight. However, here in plasma exchange,
no, I think it's we use the in general the actual weight for TPE, but the advice here is a patient above 100, we just use 100. So we don't go 120, 130. This doesn't go forever. A patient is 100, we multiply by 70. This is the maximum total blood volume. If you're 140, that doesn't mean you have 10 liters of blood in your system. This is the best guess you can estimate someone's total blood volume. After 100, it doesn't increase. So 100 will be the maximum you should use there.
Yes, another question coming from percentage of albumin used for exchange, 20 or 5%. It's only 5%. You can dilute the 20% bottles. What is the rationale of doing every other day? I think this is the kinetics. It depends on the kinetic and the disease. Some disease like anti-GPM, we have to use it daily, or TTP, we have to use it daily. Sometimes for patients, for the main IgG, we can use alternative like in ANCA-associated vasculitis. So it depends on the disease. We can modify between daily and every other day according to the disease. Do you agree with me that?
Yes, so the ASFA guidelines are very clear, and they tell you exactly which schedule to use. For some diseases, it's daily, sometimes once every 2 months.
Yes.
So it's a huge variability, depending on the actual pathology.
Anti-GPM should be daily, clear.
Yes, and regarding the albumin, each country is different. So every country, they have their own albumin bottles, and you have to go back and ask what kind of bottles in the pharmacy they have. And then we will have later in the case how to actually calculate how much albumin you will need for each replacement. So that question will be answered in the second half.
Yes, it's effect of plasma exchange on platelets. I am talking here on membrane, not centrifugation, because centrifugation is another story.
Yes, and these patients, of course, we do the TPE to cure the disease, right? So we're trying to actually treat the HUS, and in this case, one of the outcomes is to increase the platelets. So when we start with a low platelet count, for example, 50,000, we start to target to reach maybe 150,000. So the therapy should help. Nevertheless, we have to understand that this is an extracorporeal treatment, whether we are doing it in centrifuge or whether we're doing it in membrane, there is a risk of loss of platelets in general in those therapies. The advice would probably be to use it with zero heparin anticoagulation. So in this case, try to use no anticoagulation, which is another challenge that we will also explain in the second half, how to prescribe without heparin for those patients.
Last question is for this part of important part of the technique, which is only or ARBs? Should we be avoiding ARBs or just the ACE? We know the kinase effect and the bradykinin, but the patient is on ARB. Should we stop ARB as well, or only for ACE inhibitor?
Now, this is, I think, more historical. That data showed in the past that the ACE inhibitors had some sort of an allergic reaction when it came to the contact with the membrane. There is no similar guidelines for the ARBs, but I think it's more historical. The membranes used to be more less biocompatible. They used to make, but the warning still remains that ACE inhibitors should be stopped 48 hours before the treatment.
Okay, that's fine for this very important part for the technique. Now coming for the more exciting part, which is the challenges. And I think that all of us should testing their terms by these quizzes and the rationale, and we can move for the second part right now. Thank you very much.
Thank you, Professor, for the moderation.
Thank you.
An 18-year-old male patient, 80 kilograms, is admitted to the emergency room with persistent vomiting, initial lab sukariat 5.3, hemoglobin 6.5, hematocrit 30%, platelets 22,000. Hemolytic uremic syndrome was diagnosed and patient was commenced on TPE. Your colleague suggested a zero heparin prescription due to the low platelet count. Design a full TPE prescription, including patient's PECs, replacement volume, replacement flow rate, replacement solution, blood pump speed, anticoagulation, and precautions. So let's start with this patient to try to start the TPE prescription. Now, the first one, want to enter the pre-treatment hematocrit. As we explained, pre-treatment hematocrit in this case was 35%. In our case here, hematocrit is 30%, so we enter here 30%. Also, total replacement volume. What is total replacement volume? Total replacement volume would be, as we explained, we start by the patient's weight, 80 kilograms. We multiply it by 60, gives us 5.6 liters is his total blood volume. Total blood volume, we multiply it by 0.7, which is 1 minus hematocrit, gives us total plasma volume. And then we have now the GASFA guidelines saying 1 to 1.5 the PECs. 1 to 1.5 PECs means 4 to 6 liters. So one exchange is 4 liters, 1.5 exchange is 6 liters. So we want to do somewhere between 4 and 6 liters. For the purpose of this case, we will do around 5 liters. So we enter total replacement volume to be 5 liters. Again, how did we get this number? We got it by multiplying the weight of the patient by 70, gives us 5.6, and then multiplied by 0.7 brings us to 4 liters. 4 liters is one exchange. You want to do somewhere between 1 and 1.5 exchange. 0.5 exchange makes it 6 liters. So somewhere between 4 and 6, maybe do 5 liters, 5,000 ml. Replacement container, this means how big is the container that you have prepared for the replacement solution. Of course, you will ask how big is the container the nurse is prepared. Maybe we make it around 1 liter or so, that the nurse is prepared 1 liter container. We will come back to that calculation, also how to prepare the replacement, the 5 liters solution. For the purpose of this one, the nurse told you it's 1 liter, so you will put here the container is only 1 liter. Now, this is all confirmed all. You see this is the blood pump speed is 145. Nothing on the pre-replacement is how much is the replacement? The replacement is the rate that you will be replacing these 5 liters. So if you put 1 liter, that means 1 liter per hour. That means that you will be replacing it over a period of 5 hours. The problem is when you do that, when the time is over 5 hours, you get a lot of clotting. So we try to make a higher rate to make sure we finish less than 4 hours. So we try to, in this case, use a replacement rate higher than 1 liter, maybe 1.25 liters. That will also, remember, 0 heparin. We talked about this patient having 22,000 platelet count, so we wanted 0 heparin for this case. We would confirm all. And if you look at that with the blood pump speed of 145, hematocrit 30%, a total exchange of 5 liters. Now, is this a good prescription? Of course, with 0 heparin, filtration fraction here is 22%, very high. We want to go below 20%. How do I do that? Of course, you start here, continue, starting the patient, and you can see filtration fraction is 22%. So this is how the main screen looks like. Blood pump 140, 5 liters is the total replacement volume, replacing at a rate of 1.25 per hour. Therefore, you will finish in 243 meters, which is 4 hours. Of course, filtration fraction here is very high, at 22%. We want to go below 20%. How do I do that? You go to the blood pump speed. You increase the blood pump speed to reach 165, for example, filtration fraction, or 170, and then this would be the right blood pump speed for this patient. So you go back here with the filtration fraction below 18%, because remember, the patient is 0 anticoagulation. There is no heparin. Of course, if the patient was fully anticoagulated, you're allowed up to 25%. So this is a good prescription, and therefore you want to finish in 4 hours. What if you say that there is a high incidence of clotting in the last hour, and I want to finish in less than 4 hours? What should I do? Of course, this would be to increase the rate. So you adjust, you try to increase the replacement and make it maybe higher at 1.5 liters, for example. And if you do that, you will finish in 200 minutes. 200 minutes is good. It's 3 hours and 20 minutes. It is much less likely that the filter will clot. But the problem is, look at again, the filtration fraction went really high, up to 22%. So what you should do again is go and increase the blood pump speed to be able to have lower filtration fraction. Go with the blood pump speed up to 180. And therefore confirm all. You can see filtration fraction is at 22%. You're pushing your luck here with this patient being 0 heparin prescription. So 3 things here that are affecting each other: the blood pump speed, the replacement speed, and also the time. These 3 factors, you need to manipulate them very well to have low clotting risk prescription. You need to maintain filtration fraction below 20% in non-anticoagulated, 25% in fully anticoagulated patients. So by manipulating the blood pump speed and by manipulating the flow, the replacement fluid flow speed, you can achieve low clotting risk, low filtration fraction in a short period of time, finish the treatment within 3 hours, 3 hours, 20 minutes to prevent clotting. Now, this is a good prescription, a 3.5 hour, 20-minute prescription. That way. What if the doctor wants to do 1.5 packs, 6 liters? Again, you can increase the plasma flow, increase the rate, and so on. So in general, remember, if you're navigating those 3 parameters, the time, the replacement flow, and the blood pump, you can achieve certain volumes, but also with lower risk of clotting for TPE. Of course, now we know we've started the treatment. Also, the solution, what kind of solution for this case? It will be albumin or plasma. If you look at the ASFA guidelines for this disease, the hemolytic uremic syndrome disease, it will be either albumin or plasma. Anticoagulation, we said no anticoagulation. Precautions, we will use, for example, albumin. In specific country, you should always try to find out the composition of the albumin you have in your country. If I will give you an example, in some countries, they use 100 ml bottles of 20% albumin. Means that each bottle of those has 20 grams of albumin. And how do I calculate how much albumin do I need for this patient? It's very easy. Total volume is 5 liters. How many grams of albumin are in a normal person, normal human being? It is 50 grams per liter. So 50 grams per liter means 5 grams per deciliter. So 50 grams per liter and multiplied by 5 liters, that is 250 grams of albumin. If the bottle has 20 grams of albumin, we will need around 12 bottles of albumin for that patient. So I will prepare the fluid, 5-liter fluid, and I will put 12 bottles of albumin. How much is the volume of that albumin? The 12 bottles together is 1.2 liters because one bottle is 100 ml. So if you put 12 bottles, you have 1.2 liters. What about the rest of the 5 liters? The patient has to be compensated 1-to-1. So we have to prepare 5 liters of replacement fluid. 1.2 liters will be albumin, 12 bottles. The rest is 3.8 liters of something. Of what? As we explained, Ringer lactate, Ringer acetate or plasmalite, potassium-containing solution to prevent hypokalemia. So the trained nurse will prepare 3.8 liters of Ringer lactate plus 12 bottles of albumin to have a 5-liter container to do 1-to-1 replacement of this patient. What about if it is fresh frozen plasma? Again, fresh frozen plasma, it depends how big is the bag in your country. Some countries, the bag is 250 cc, sometimes 300, sometimes 200 cc. Example in your country, for example, 250 cc, we have 5 liters of replacement. How many bags are that? That is 5 liters. Each liter is 4 bags. So that's 20 liters, 20 bags of plasma. That's a lot of plasma. So therefore, you need to order 20 bags of cross-matched plasma for this patient to be able to do 5-liter replacement. In real life, sometimes this is impossible. What do? We are allowed to go to 1 exchange, 4 liters instead of 5. We can do combination of plasma and albumin, half-half. It depends on as we explained, the resources, how much is the bag of plasma, how many bags of plasma, how much is the albumin, how many bottles of albumin, and so on. I hope you enjoyed the practical session. This is the situation now of our case. As we explained, these are the parameters for the prescription. We talked about the blood pump speed, the rate of replacement. We talked about filtration fraction and the time of the treatment. My name is Dr. Kamel El-Attar, and I wish you the best of luck with the rest of your treatment. 18-year-old male patient, 80 kilogram, admitted to the emergency room, persistent vomiting. Initial labs show creat 5.3, hemoglobin 6.5, hematocrit 30%. Platelets to 22,000, atypical hemolytic uremic syndrome, also known as complement-mediated thrombotic microangiopathy, was diagnosed and patient was commenced on TPE. Your colleague suggested 0 heparin prescription due to low platelet count. Remember the case? First question, according to the ASFA guidelines, which category is this disease classified? So A, category 1, B, category 2, C, category 3, and D, category 4. If you go through the ASFA guidelines, you will find that HUS is a category 1. So this means first-time treatment. According to ASFA guidelines, how many PECs should be performed every session? We get this from the technical notes. A is a 1 exchange, B 1 to 1.5, C 1.5 to 2, or D more than 2 PECs, more than 2 exchanges. The correct answer, as per the ASFA guidelines, is 1 to 1.5. So we have the correct answer is B. Approximately, what is the patient estimated plasma volume? As we know, patient has a weight is 80 kilograms, and the patient multiplied by 70 gives us 5.6 liters. That is his total blood volume. 5.6 liters multiplied by 0.7, which is 1 minus hematocrit. Hematocrit is 30%, brings us to around 3,950 ml, which is around 4 liters. So the 1 exchange would be, his estimated plasma volume is around 4 liters. The correct answer is C, 4 liters. How much is the total exchange volume in this case? Of course, total exchange volume is total plasma volume, estimated plasma volume multiplied by 1 to 1.5. A, 1 to 2 liters, B, 2 to 3 liters, C, 3 to 4 liters, or D, 4 to 6 liters. Of course, here the correct answer is D, 4 to 6 liters, 4 being 1 exchange and 6 being 1.5 exchange. So the correct answer is somewhere between 4 to 6 liters. In this case, for example, you decide to do 5 liters, somewhere between 1 and 1.5 exchanges. Second case is antibody-mediated rejection case. 38-year-old female patient weighing 76, admitted to the emergency room with fever. History reveals that she underwent a kidney transplant operation 1 month ago. Examination reveals 39.6 degrees fever, tenderness in the iliac region. Lab results reveal hemoglobin 8.5, hematocrit 32%, TLC 11,000, platelet count 75,000, creatinine 4.6, and potassium 4.5. Nephrologist decided to perform renal biopsy and is positive for C4D. Antibody-mediated rejection was diagnosed. The recommendation was to start TPE immediately. Again, according to ASFA guideline, under which category is this disease classified? A, category 1, B, category 2, C, category 3, and D, category 4. If you look through the ASFA guidelines, as we explained, you will find that correct answer is A, category 1. According to ASFA guidelines, how many PECs should you perform every session? A, 1 exchange, B, 1 to 1.5 exchange, C, 1.5 to 2, D, more than 2. The correct answer here is B, 1 to 1.5 exchanges. How much is the total exchange volume? Now, how will we be able to calculate that? Patient, remember, is 76 kilos. You multiply 76 kilos by 70. You get 76 kilos multiplied by 70, brings you 5.32 liters, multiplied by 1 minus hematocrit. What's the hematocrit again? 32%. That is 1 by 0.68. So this gives you a total of 3.6 liters of plasma. This is, as you can see here, 3.6 liters of plasma. How much is the total exchange volume? As we said, 1 to 1.5, the baseline. So 1 to 1.5, the PECs. So here the 1 is 3.6, multiplied by 1.5 goes up to 5.4. So 3.6 to 5.4 is the correct answer. The answer is A in this case. According to ASFA guidelines, what is the recommended replacement fluid? Is it exclusively albumin, or exclusively fresh frozen plasma, or albumin and or fresh frozen plasma, or exclusively cryoprecipitates? If you again go to the ASFA guidelines, the technical notes, you will find albumin and or fresh frozen plasma. 53-year-old female patient, 92 kilos, arrived at the emergency department complaining of weakness and discomfort in her extremities. She explained she had been feeling numbness and tingling in her toes for 2 weeks now, with symptoms progressively worsening. 1 month prior, she was diagnosed with COVID-19 and attributed her symptoms as the residual effect of the infection. Over the past 3 days, she had experienced increased weakness, impaired motor skills. She noted a specific difficulty holding her toothbrush and brushing her teeth, influencing her to seek medical attention. Due to her rapidly progressive signs and symptoms, she was admitted to the hospital. CBC reviews hemoglobin 12, total leukocytic count 7,000, platelets 220,000, hematocrit 35%. Her status worsened the next week. While in hospital, she was unable to move her upper or lower extremities and had trouble breathing and swallowing. She was admitted to the ICU, where she was provided with supplemental oxygen to assist her breathing and an NG tube to provide nutrition. Interdisciplinary medical team diagnosed her with GBS, Guillain-Barré syndrome, decided to start TPE. According to ASFA guidelines, under which category is this disease classified? A, category 1, B, category 2, C, category 3, and D, category 4. Again, according to the ASFA guidelines, GBS is a category 1, so the correct answer is A. According to ASFA guideline, how many PECs should you perform for every session for the GBS? A, 1 PECs, B, 1 to 1.5, C, 1.5 to 2 or more than 2 PECs. The correct answer here is B, 1 to 1.5 exchanges. Approximately how much is the total exchange volume? Let's go back to the patient to see how much is the total exchange volume. Again, patient's 92 kilos. So you have 92 kilos, you multiply it by 70, you get 6.4 liters. 1 minus hematocrit multiplied by 1 minus hematocrit is 35%, so multiplied by 0.65, you get 4.1 liter, 4.18, so almost 4.2 liter. The correct answer here would be 4 liters to 6 liters. Again, as we explained, this is one exchange is 4 liters, 1.5 exchange is 6 liters. So D, 4 to 6 liters would be the correct answer. Adverse effects of TPE are common but usually mild. Adverse effects of TPE may include all of the following except fluid imbalance with hypovolemia or overload, fever and or chills, C, hypocalcemic citrate reaction ranging from paresthesia to arrhythmias, D, disequilibrium syndrome. Of course, we've talked about the complications of TPE. They included, of course, as we explained, fluid imbalance. We explained it could include fever or any allergic reactions. We explained hypocalcemia, both in plasma replacement and in albumin replacement. We did not mention disequilibrium syndrome. Disequilibrium syndrome is a special syndrome that happens when the patient is starting intermittent hemodialysis. They have too fast clearance, and that causes disequilibrium syndrome. This is not described in TPE treatments. Which of the following is a clear advantage of using albumin as a replacement fluid over fresh frozen plasma? Why is albumin better if you had the option? Remember, some diseases you have the option of choosing between albumin and plasma. What is one of the advantages of albumin? A, no coagulation factors. B, less allergic reaction. C, no immunoglobulins. And D, higher risk of hepatitis and HIV. Let's look at them. First one, no coagulation factor, that's not an advantage. Of course, that's a big disadvantage for albumin. Albumin, when you replace, you don't have a coagulation factor, so it's a clear disadvantage. Less allergic reactions, yes, this is a very big advantage versus the flash frozen plasma. Though some patients may develop allergies from albumin, it's much less common than developing allergies from the fresh frozen plasma. So B is the correct answer. C, no immunoglobulins. Big disadvantage. Again, albumin does not contain immunoglobulins. There is a higher risk of infection. And of course, having higher risks for hepatitis and HIV, of course not. It has the lower risk of hepatitis and HIV. This is a clear risk when replacing with fresh frozen plasma. The fourth case is a 27-year-old female began to experience gradual progressive bilateral upper limb weakness and dropping of the left upper eyelid. Over time, she was further worsening of upper limb weakness, double vision, exhaustion. Patient also had noticed mild oropharyngeal symptoms, including dysarthria, dysphagia, difficulty chewing. Lab results reveal anti-acetylcholine receptor antibodies 0.65. Normal is from 0 to 0.4, so high. Pyridostigmine tablets of 30 milligram potency were commenced twice a day, initially for 3 days, while monitoring for cholinergic side effects like nausea, vomiting, abdominal cramps, and loose stools. Yesterday, she was admitted to the emergency room with a myasthenic crisis. Neurologist prescribed 6 TPE sessions with 3-liter exchanges every other day. So IVIG alternating with TPE. 1 day TPE, second day IVG, and so on. According to ASFA guidelines, under which category is this disease classified? A, category 1, B, category 2, C, category 3, and D, category 4. You will see in the ASFA guidelines, myasthenic crisis, TPE is category 1. According to ASFA guidelines, what is the recommended replacement fluid for this patient in myasthenic crisis? A, exclusively albumin. B, exclusively fresh frozen plasma. C, albumin and or fresh frozen plasma. D, exclusively cryoprecipitate. And the correct answer is exclusively albumin. A. Why? In this case, this disease, it is specifically mentioned the replacement fluid to be albumin. You start TPE and you want to instruct the nurses about the rate by which to administer replacement fluid. All the below are factors that affect filtration fraction except A, blood pump speed, B, patient hematocrit, C, replacement flow rate, D, type of replacement fluid, whether fresh frozen plasma or albumin. Correct answer, of course, D, type of replacement fluid. Doesn't matter whether you're using albumin or fresh frozen plasma. It doesn't matter to the filtration fraction. Filtration fraction is a formula built in inside the machine that takes into account the blood pump speed, patient hematocrit, and the replacement rate. So the higher the blood pump speed, the lower the filtration fraction. The higher the hematocrit, the higher the filtration fraction, and the higher the replacement rate, the higher the filtration fraction. So all these factors affect filtration fraction except the type of fluid. 2 hours into the treatment, you get a high transmembrane pressure alarm. All of the below are actions that may lower TMP, except lowering blood pump speed, A, B, increasing replacement fluid rate, C, increasing dose of anticoagulant, D, increasing treatment time while maintaining the same total exchange volume. Lowering the blood pump speed will lower the transmembrane pressure. So these A is correct. Increasing replacement fluid will increase the transmembrane pressure. So B is not correct. So B is the right answer because increasing the replacement fluid rate would make the transmembrane pressure higher, not lower. Therefore, it is the only exception here. Increasing the dose of anticoagulant may lower transmembrane pressure. Increasing treatment time while maintaining the same total exchange volume, meaning lowering the rate, may increase transmembrane pressure. So all of them may increase transmembrane pressure, except B will always increase transmembrane pressure. When using exclusively albumin as a replacement fluid, all of the following are useful precautions except A, prophylactic infusion of calcium chloride during treatment to prevent hypocalcemia. Is this important? B, warming the replacement fluid to prevent hypothermia. C, ensuring a potassium concentration of 4 millimole in the replacement solution to prevent hypokalemia. D, 2 units of fresh frozen plasma at the end of the session to minimize bleeding and infection risk. Of course, remember albumin versus plasma. In this specific myasthenic crisis, the recommendation is exclusively to use albumin. Of course, it's important to prevent hypocalcemia. You have to give calcium infusion because albumin does not have calcium. So A is correct. Warming the plasma replacement fluid is not important. Again, this is important only when we are using fresh frozen plasma, but albumin will be replaced at room temperature. Warming it is not a very important step. So B is the correct answer. C, ensuring potassium, of course, very important. Use 4 millimole potassium, as we explained, either plasmalite or ringer lactate or ringer acetate potassium-containing solutions to prevent hypokalemia. 2 units of fresh frozen plasma at the end of the session to minimize bleeding and infection risk. As we explained, even if you're using exclusively albumin, it's good advice to give a couple of fresh bags of fresh frozen plasma at the end of the session to prevent bleeding risk and infection risk. Goodpaster syndrome, the first symptom in a 19-year-old female patient were caused by anemia. 2 months later, she reported symptoms of pulmonary hemorrhage. At the end point of this, she already had renal insufficiency and was immediately hospitalized. The same day, you started therapy with steroids, endoxan, and plasmapheresis was initiated. According to the ASFA guidelines, under which category is this disease classified? Remember, anteroglomerular basement membrane disease, also known as Goodpaster syndrome, A category 1, B category 2, C category 3, and D category 4. The correct answer is A category 1. You start daily TPE sessions with the following prescription: 3 liters of total plasma exchange volume over 3 hours, placing with albumin only, anticoagulation with heparin, 1000 international units per hour. Blood pump speed is 120. Given that the patient hematocrit is now 35%, what will be her filtration fraction? Again, more of a mathematical, it's a formula built in the machine. In the formula, in the numerator, you have UF. In this case, UF is 1000 ml per hour. So 1000 would be ml per hour divided by blood pump speed multiplied by multiplied by 1 minus hematocrit. In this case, the formula will come up with filtration fraction 21%. So, it's good to know it on the machine. Even if you don't know the formula, it's fine. If you put these parameters on the machine, blood pump 120, replacement 1 liter per hour, you, with a hematocrit of 35%, you will get a filtration fraction of 21%. 1 hour into the treatment, she develops an attack of hemoptysis. Nurse stops the treatment immediately and calls for your consultation. You recommend all of the following changes to the prescription, except stopping heparin administration immediately, B, using plasma as a replacement fluid instead of albumin, C, increasing replacement fluid to 1,250 to shorten the treatment duration, D, increasing blood pump speed to 180 ml per minute to lower filtration fraction. So these are the interventions that you have a patient who develops an attack of hemoptysis. You want to stop it immediately. Stopping heparin administration, of course, A is correct. So, we should stop, of course, heparin administration. B, using plasma as a replacement instead of albumin. Not a bad idea because plasma does have some clotting factors. C, increasing plasma replacement flow rate to shorten the treatment duration. This will not help in this case very much. Increasing the flow rate will not help with the hemoptysis. Increasing blood pump speed to lower filtration fraction may help because now we are already stopping the heparin. So we want to have a lower filtration fraction than the 21%. So what do? We increase the blood pump to lower the filtration fraction. So all of them are correct except C. C would be the right answer. Nurse resumes TPE session after following your new prescription. 1 hour later, patient develops severe hypothermia and chills. You recommend all of the following except increasing the temperature of the machine blood warmer. B, ask the nurse to further warm the plasma and use bear huggers. C, increase plasma flow rate to 1,250. D, increase the blood pump speed to 200. Now, this is a case of hypothermia. In this case, what do I do with hypothermia? Of course, increasing the temperature of the blood warmer is a good idea. So A is correct. B, ask nurse further warming the plasma or using bear huggers. All this will help. So B is correct. C, increasing plasma flow rate. So when you increase the plasma flow rate, remember plasma is cold. So when you increase the plasma flow rate, you're going to increase the exposure of your patient to the cold fluid. So C is incorrect. C is the right answer. Increasing the blood pump speed. When you increase the blood pump speed, you decrease the time by which the blood is going to lose the heat by convection, therefore increasing the blood pump speed by conduction and convection, the loss of heat will be less. So increasing the blood pump speed may help with the hypothermia. But increasing the flow is not going to help. It's going to worsen because the fluid is cold and you're going to be using it, more of it per hour, so means more exposure to the cold fluid. I hope you enjoyed the cases. Of course, there is a lot of explanation in the ASFA guidelines itself. If you always want to refer to it when you are studying or even just when you are wondering what to prescribe. I wish you the best of luck with the rest of the training.
Thank you very much for this interesting talk and description of the patient cases. I am taking a look here in the chat. There are a lot of questions. I try to summarize. So one question is about the choice between plasma and albumin. So I guess we follow the guidelines. Each disease that we want to treat is very well described in the guidelines, and this will be our first advice that we take. We follow the guidelines. Then there is a question here, can we mix albumin and plasma so that we, for instance, start with albumin and then we go over to plasma? What about this? What is your opinion, Dr. Kamel?
Yes, and I've seen the question being repeated, and I think we try to answer it through the cases. Obviously, there are many diseases, over 108 diseases that are category 1. And as a nephrologist or as an ICU doctor, you're not an expert in all the prescriptions. So you need to go to the ASFA guidelines to see what they say about it. And if they say strictly albumin, that means strictly albumin. If they say strictly plasma, that's strictly plasma. But most of the diseases are albumin/plasma, means you have the choice between albumin and plasma. In this case, 50-50, 1/3, 2/3, depends very much on your resources, the costs, the availability of the bags, the availability of the cross-match bags. All these are factors in real life that actually determine your replacement fluid rather than the science. The science is clear. If it was exclusive albumin, you should just go for it. If it was exclusive plasma, you should just go for it. Otherwise, it's left for you. The only thing that you should learn from what we mentioned today is how to calculate your bag. How can I make a 5-liter bag out of albumin and plasma? How many liters of albumin? If I'm doing 3 liters, again, each liter should have 4 to 5 grams per deciliter, meaning 40 to 50 grams of albumin, and so on. So if you got the right way to replace, you can do whatever you want.
Then I see an interesting question here about how to monitor the coagulation status of the patient. So is there any analysis that is the best? For instance, should we do thromboelastography or RUTEM? Could this give us a hint of where we are regarding the removal of the coagulation factors? Or is there a need to monitor this during the treatment?
So usually what we do in a normal TPE session is we monitor APTT. We want to see that our patient is fully anticoagulated. So we try to start by doing the initial APTT, which is called the baseline. Let's say, for example, 40 seconds. And then we try to achieve 1.5 to 2 baseline, meaning going from somewhere between 60 and 80 seconds. So if you measure your patient is at 42, 43, that means you're not anticoagulating it properly. That means you need to increase the heparin dose to reach your target. That could be tricky with TPE because the session is really short. So sometimes you don't have the time or the luxury to be able to measure, wait, and then adjust and so on. So the advice usually is to do a good prescription. So we explained what a good prescription looks like, low clotting risk prescription. And if you can, try to keep the patient within 1.5 to 2 baseline. This is the normal guidance that we use for anticoagulation.
Yes. Here are many questions. I will take one more. It is about how well the patient will tolerate this treatment. So, for instance, if we have a patient who is on norepinephrine infusions are there, can we anticipate that this treatment will also remove molecules that we do not want to be removed and, for instance, change the patient's hemodynamic status? What about this?
Absolutely. So again, we will remove the plasma with everything in the plasma. So everything goes, antibiotic goes, vasopressor goes, everything will go during the treatment. So what do? We start with hemodynamically unstable patients. We start very gradually. So we start the therapy with a very slow blood pump speed, and then we wait and we measure the MAP and we adjust norepinephrine doses, go up a little bit, measure, norepinephrine. If MAP is okay, adjust the dose and so on until you reach your final blood pump speed. So you start, for example, by 80 ml, 100 ml, 120, 140 until you reach 160, which would be your final, and then you can continue the treatment. So some of these patients are critical. They are hemodynamically unstable on vasopressor. They still need the TPE. So in that case, be careful and try to do a gradual, as we explained, the takeoff and the landing is the most critical part for those patients. Another advice is to do what we know as a dry connection. So connect both the artery and the vein at the same time when you are doing it, so that the patient does not lose any during the connection. During this connection, also try to keep the patient as hemodynamically. So using a closed system or a dry connection would be better for the hemodynamically unstable patients.
So time is flying, but I will end with my own experience. Often we also see that the patient actually stabilizes when we start the treatment. And I think the reason is that we remove cytokines that cause the vasoplegia in the patient. So it can be either way with this treatment, but of course we need to monitor the patient very carefully upon starting the treatment.
Absolutely. We are improving the hemodynamics by treating the actual disease, of course, but also remember we're cooling. We're cooling the blood. We are cooling it either by using plasma or room temperature. So the cooling effects also usually ends up with some reactive vasoconstriction, and this reactive vasoconstriction increases the MAP a little bit. So yes, absolutely, your observation is absolutely true.
Thank you very much. I will give over to Professor Amr.
Thank you so much, Dr. Marcos, Dr. Kamel, Dr. Hesham, Dr. Jacob. This was a very fantastic session today. I think we are all has gained the new information and learned today. Just some closing remarks here. By tomorrow, all of our attendees should receive the YouTube link of the recorded webinar. By next week, all of our attendees should receive certificates of attendance. And with that, I hope the best for you, and have a good rest of your day, your afternoon, your evening, your night.
Thank you for the moderation, Professor. Have a nice evening, everyone.
You too.
Thank
Bye.
you.